by a team of addiction specialists. So it's a fantastic addition to the service to be able to call on that expertise when we need it. And we have Dr. Kavita Seth and Dr. Catherine De Cruz, who lead that service and are going to present to us today on a long-acting injectable buprenorphine. Thank you so much.
Thanks so much. Okay, good morning, everyone. Yes, so this is Dr. Kavita Seth. She's an addiction psychiatrist, and I'm Catherine De Cruz. I'm a GP, and I have a special interest in addiction medicine. And together we look after the addictions unit at Ramsay Clinic Hollywood. And so Dr. Seth and I thought that a good update in addiction psychiatry. Oops. Oh, did it work? Didn't work.
Hear it.
Which one? Yeah, so Dr. Seth and I thought that a good update in addiction psychiatry should include the long-acting injectable buprenorphine, known as the LABs. That's Buvidal and Sublocade, which is basically a depot buprenorphine in a weekly and monthly formula, because it's the most recent update in opioid substitution therapy. It's really the most recent in the last 20 years, and it is for the treatment of opioid dependence disorder. And I'm very happy to share my experience with this because I was fortunate in 2019, when I was working at Next Step East Perth, to be part of the initial rollout of Buvidal. And at the same time, Cambridge Clinic was given Sublocade to roll out. And both Next Step and Cambridge Clinic found that this depot buprenorphine was very, very beneficial. All the patients that we started on Buvidal were heroin dependent, and they were all on an opioid substitution therapy, which was Suboxone. And whilst some were doing extremely well on that, there were others that weren't doing well at all. And there was quite a few that were constantly relapsing back to heroin, missing doses of their Suboxone, and needing to be reinducted. And that came along with all the, associated health issues, legal issues, social issues. And so these were the patients that did extremely well when we put them on Buvidal, because being a monthly injection, it gave them a very steady, stable dose of buprenorphine, which really made their condition more stable. And the other thing it did was it really reduced their risk of wanting to relapse. All their cravings seemed to disappear. They used to say to us, with this injection, I can be amongst a crowd of people that are using, and I really don't care. I simply don't want to use. And this was amazing. It was fantastic to see. So now we had patients, who obviously were still dealing with an addiction, but whose life was now stable, less chaotic. The other advantages were they didn't have to go to a pharmacy every day for dosing anymore. And so they could get more work opportunities, even FIFO if they needed. They could travel now, which was something they couldn't have done before. And in addition, they were saving money, because maintaining a heroin addiction is really expensive, actually. Back then, a point of heroin was about $50, and some of them were using 6 points a day. And every day we're talking, so that really adds up. And in addition, the timing of these new labs was amazing, because it was in 2019, which was the eve of COVID. And so, during lockdown, it was really difficult for patients to go to a pharmacy every day. I mean, almost impossible. So having a monthly injection at that time was really beneficial. And also, with the borders closed during COVID, the illicit drug trade basically dried up. So now there were no there was no heroin, there was nothing. And so this brought a lot of the people out of the woodwork, really, and they were looking to start opioid substitution. So it came along definitely at the right time. So this is the number of drug-induced deaths in Australia in 2022, and that's a really big number. And 80% of that number is unintentional or accidental drug-induced deaths, like opioid overdose. And that's also a big number. And in comparison, it's even a bigger number than the road toll for that year. So the scale of the problem is really big. And then the other little graph indicates that 2/3 of the accidental overdose deaths due to opioids occurred in people that were aged 40 and over in 2022. So they're just some interesting figures. So a big problem like that warrants a good treatment. And that's where opioid substitution therapy comes in. So it is to reduce harms associated with non-medical use of opioids or illicit opioids. And it does reduce the risk of overdose and gives people the opportunity to regain control of their lives. And this is what we found, definitely. And of course, the other benefits include if they become more stabilised, they stay in programs longer, and it reduces all the health issues like bloodborne viruses and including infective endocarditis from dirty needles. Definitely their health and wellbeing improved, and they were able to get involved more with work and education, and there were definitely less overdoses and drug-related crime. And this is the evolution of the opioid substitution program. So the LAPEs were the first significant change in nearly 20 years. So in 1994, methadone was started, and that was really groundbreaking at the time. And then in 2001, the newer sublingual buprenorphine or Suboxone came about. And that was a huge improvement because Suboxone is very much safer than methadone, and I'll get into that later. And now, finally, we have a depot buprenorphine. And the way it works. So opioid substitution replaces a short-acting opioid such as heroin or oxycodone with a long-acting opioid that can be taken orally. And the opioid substitution has a minimal intoxicating effect itself. It blocks the euphoria associated with using other opioids, and it's very good at preventing opioid withdrawal. And just as a general comment, OST with methadone and buprenorphine is appropriate for those significant opioid dependence wishing to cease their illicit opioid use. And it is appropriate to engage patients in treatment for 1 to 2 years for better outcomes and enduring lifestyle changes. Of course, there are other treatments for opioid dependence disorder, and one would be opioid withdrawal. And some patients don't want to go onto a program. They say, I just want to get off. I've dug myself into this big problem. I just want to get off, and I never want to touch it again. And a lot of our patients at Hollywood are like that. So we will do a slow taper of their whatever opioid they're on. Sometimes we need to use a little bit of buprenorphine, just a little short regime of Suboxone, because it can really help with the opioid withdrawals. But then clonidine is a very useful medication for opioid withdrawal symptoms. The only limiting factor, of course, is hypotension. And then, of course, you've got your other, symptomatic treatments there. But it's very important to keep in mind that following opioid withdrawal, patients will be at a really high risk of overdose if they use opioids again, and that's due to the reduction in their opioid tolerance, as well as having ongoing cravings. So sometimes we make patients very vulnerable if we take them off opioids, because if they used again, maybe they will have an accidental overdose. So sometimes opioid substitution therapy is really the safer option. However, if they insist and really want to come off the opioids, then it's really important to give them a form of naloxone. And the best one these days is intranasal Nixoid after the withdrawal, because it is a potent opioid antagonist for the treatment of opioid overdose. And that's what it looks like. That's Nixoid packet. Now, a lot of pharmacies will give this out for free, so the patient just has to ask for it, and most pharmacies will participate in that. And so Nixoid is a nasal spray, and there's 2 in the box. And the reason for that is if someone is found to have an opioid overdose, it's just a spray up the nostril. And sometimes the Nixoid will wear off before the overdose wears off. So that's why there's 2 in the box. And then, of course, you need to get help, ask for help. So what are the types of opioid substitution therapy? Well, there are full agonists and there are partial agonists. So the full agonist is methadone, and methadone produces a maximal effect when it binds to the mu opioid receptor. And because it has that full effect, it has to be titrated up very slowly, and it has more side effects and more risks because it's more sedating, and it can more easily cause overdose and respiratory depression. And that's particularly if it's combined with other CNS depressants like alcohol or benzos. So the better option really is the partial agonists, which is all the buprenorphines, so Suboxone, Subutex, or the new Laves, because they produce a submaximal effect when they bind to the mu opioid receptors, even with increasing doses, and that's called the ceiling effect. So it doesn't matter how high the dose goes, it still causes less sedation, less respiratory depression, and less risk of overdose. So that one we can induct a lot quicker because it's basically a lot safer. Just probably leave the rest of that. So the oral buprenorphine formulations, so it comes as Subutex and Suboxone. So Subutex is plain old buprenorphine, and it is in a tablet, and you just put the tablet under the tongue, and it comes in those 3 doses, 0.4, 2, and 8. And just in comparison, Temgesic, which is a painkiller, is 0.2. So these doses are a lot higher. And then the Suboxone sublingual film, and that's buprenorphine and naloxone in a ratio of 4:1. And that comes in 2 doses, the 2 milligram 0.5 and the 8 milligram/2 milligram. So why was Suboxone developed? So it was developed to prevent the intravenous injection of Suboxone, because believe it or not, some people do try to inject it. And so that then the naloxone will attenuate the buprenorphine if it's injected, but if it's used the right way sublingually, then naloxone has no effect. And the bioavailability of Suboxone depends on how long it is in contact with the oral mucosa. And so it can vary with patients, because some patients, I don't know, they put it in all sorts of places in their mouth, I've seen. You know, you say put it under your tongue and now it's stuck on their lip, and you go, what's it on your lip for? And then once it's stuck, it's really hard to get off because it's sort of like it's designed to actually stick. So then they're like peeling it off, and anyway, eventually patients do get used to it. It's quite hard to do though. And initially you need to put it like standing in a mirror, because if you try and put something under your tongue that's a film, I don't know, it's just hard to know where you're putting it. And yeah, so anyway, so that's one of the downsides of the film. The half-life of buprenorphine is really long. It's 20 to 72 hours, and time to steady state is about 7 to 10 days. And we also just have to keep in mind drug interactions that can cause more sedation. So now the criteria for starting opioid substitution therapy, well, the patient has to be opioid dependent. And so to know if someone's opioid dependent, you have to get a proper history, do a urine drug screen, and do a physical examination, because often they'll have hallmarks of using with, you know, intravenous marks on their arm. Or the other reason you can use it is to prevent relapse. So they have to have had a history of previous illicit use, and they will say they have ongoing cravings and they have a high risk of relapse, and then it's also appropriate to use OST. But we have to keep in mind that their opioid use has to have an illicit component, like heroin or prescription opioid misuse. It's not actually a treatment for chronic pain. And some pain specialists would love it. They'd love to put their patients on it because it's long acting, you know, it's convenient, but it's not for chronic pain. It is, though, if they have an illicit component. So they're patients with chronic pain that have been doctor shopping or getting it off Telegram or off the black market, then it's appropriate. The patient does need to give informed consent. They need to know what they're getting into. You know, they're buying into quite a, you know, they have to go to the pharmacy every day. It's also a drug of addiction itself. So we tell them that now they're going to be dependent on Suboxone, on buprenorphine, and they need to know what. So, and there's lots of good literature. There's lots of lovely booklets and things that you can give patients. They also need to locate a pharmacy for daily supervised dosing, and this is every day. They have to go to the pharmacy, including Sundays and public holidays and Christmas Day. So they have to find a pharmacy that's open during those holidays. They have to pay for it. There is the cost of the prescription, and there sometimes is also an additional dosing fee when they go in. And the most important thing they need to know, and a lot of them don't like this, is that their details will be recorded in the Department of Health's Drug of Addiction record of drug-dependent persons. So what that is, they are put on a record, and if they're on the record, if the patient requires a Schedule 8 medication, the doctor must apply to the Department of Health to obtain authorisation before prescribing. But this doesn't prevent the use of S8s in a medical emergency. And they also are told that information about any person on the record can be provided to health professionals, but it's not available to employers, the police, or any other government agency. And they can come off the record, and that's if they haven't used any illicit drugs or they're not on any programs after 2 years, if a medical practitioner applies to the Department of Health to remove their name. And if that doesn't happen, then they're on it for 5 years post they're not using anymore or any other programs. So if the patient says, okay, I want to start Suboxone, then this is what happens. So the prescriber needs to be authorised, which means they have to have done some training, and an individual authority must be obtained for each patient. So before you start, the patient has to be in mild opioid withdrawals. Otherwise, something called precipitated withdrawals will happen. And what that is buprenorphine has a really high affinity for the opioid receptor, and it will jump on that receptor and throw everything else off, whatever you have been taking. And initially, the buprenorphine, its effect isn't really that strong initially. So you're just leaving the patient with virtually nothing on their receptor, and they will go into full-blown withdrawals. And I've seen it, and it's really not pleasant to see at all. And it's not something you really want to do to someone. And the only thing you can do is wait it out, because there's not much you can do about it. You've got to let that buprenorphine kick in. So what we do is never start them unless they're in mild to moderate withdrawals, which would be no heroin for at least 6 hours and no methadone for at least 24 hours. And I found actually with methadone, it should be longer than 24 hours. It seems to hang around a long time, methadone, on the receptor. And then if you do commence, it's usually 2 to 4 milligrams of Suboxone to start with, and you can rapidly increase to a maintenance dose of 12 to 20 milligrams as quick as 4 days. And that's if they're opioid dependent, but obviously slower if they're not on any opioids, if they've been weaned off. And the reason you can go that quickly is because it's a partial agonist, and it's got that ceiling effect, so it's quite safe to do that. And the maximum dose is 24 milligrams a day or 32 milligrams second daily. And the reason for second daily is it's such a long-acting medication. Some patients are quite comfortable to dose every second day. And as I said, they need to attend a pharmacy every single day, initially, at least for the first 6 months. Now, if everything has gone well and it's been 6 months, they've been dosing every day, they've been coming to all their medical appointments, there's been no issues reported by the pharmacy, then they qualify for one takeaway dose, which is really nice because now maybe they can have Sunday off, you know. And every 6 months, if everything's going well, they get the privilege of another takeaway dose. And then, so after 2 years, they might have 3 takeaway doses. And that makes their life so much better. So they'll go to the pharmacy, they'll get a takeaway for the next day, then they'll go back to the pharmacy. But they are still on this program very much chained to a pharmacy, having to go every day. And that's why the long-acting injectable buprenorphines, the LAVs, have been so amazing. It's really freed people up. And so the reason they were introduced is to reduce the stigma associated with daily dosing, to free up time otherwise spent attending dosing appointments. And there is a flexibility of the dosing window, which I'll explain later. So it's very convenient for patients to go and have injections when it works for them. And there's less medical risk of diversion of medication to others. And as I said, some patients still want to inject their buprenorphine, so it gets rid of that problem. And these are the different formulations. So there's Buvidal and there's Sublocade. So Buvidal comes in weekly and monthly injections. There are 4 doses of each, as you can see. And the nice thing is it's stored at room temperature. And Sublocade is only available in 100 and 300 milligrams weekly, weekly or monthly, and there's a regime for how to use Sublocade. But that one does need to be refrigerated. And it's just important to note that Buvidal or Sublocade is never to be given directly to a patient because of the risk of diversion or intravenous injection. Because if they inject it intravenously, it will form a highly viscous liquid crystal gel upon contact with body fluids, which will definitely cause occlusion, local tissue damage, and thromboembolic events. So it can only be given by a health practitioner, either a doctor, a nurse, or a pharmacist. They're never to be given directly to the patient. Now, patients can be directly initiated off heroin, let's say, straight onto the injection. And as we mentioned before, they still need to be in mild to moderate withdrawals. And that's pretty much what we've said before with the 6 hours with heroin and methadone 24 hours or more. And then if this is what they recommend if you're going to start a patient straight from a short-acting opioid straight onto Buvidal, that you use the Buvidal weekly 16 milligram as the initial dose. And then they have the 8 milligram doses too, and they can be administered like every second day if needed. And then if the patient's still uncomfortable in withdrawals, you can every second day give them a little top up to a maximum of 24 or 32 milligrams during that week. And then you'll know what injection to give them next week. So then you'll know sort of what level they're up to. And the other way to do it is to switch them directly from Suboxone, the film, over to Buvidal. And this table is really good little table. And I use this a lot. It was my go-to because it just makes it so easy. So if the patient's on, say, 16 milligrams of Suboxone, you know that that's equivalent now to 24 milligrams of the weekly or 96 milligrams of the monthly. And when we first started rolling this out, of course, we were terrified of the monthly injection because it was brand new. So we had everybody on the weekly. And then as our confidence grew, because it was so well tolerated and they did so well on it, we thought, oh, forget the weekly. We're just going to go straight from Suboxone to the monthly. And it actually worked really well. And it was very well tolerated and patients did really well on that. So this little table was really handy. And this is a little graph with the pharmacokinetics. And it just, the first one compares being on Suboxone, daily dosing, and the weekly. And as you can see on the first graph, the up and down every day of the dosing with Suboxone. And then with the weekly, you get that lovely, stable, steady state dose, which slowly tapers towards the end of the week. And then the next graph compares the weekly with the monthly injection. And again, with the weekly injection, it drops a little bit up and down, up and down. But then the monthly with that green line is lovely. They get that absolutely stable dose. And it hardly even tapers at the end. So this has been hugely beneficial for the patients. It makes everything, their whole life much more stable. Okay, so just a little bit about how, when you've got somebody on the treatment now, what you would do with the weekly dose. So you can give the weekly dose either 2 days before the end of the week or 2 days after. So on day 5 or day 9. And then if you need to, there's also the top up, the weekly top up of the 8 milligram injection if needed. And then at the end of that first week, then you know what the next, what injection to give the next week, because you have an idea what the patient needs. And then the same with the monthly. So with the monthly injection, you can give the injection up to 1 week before the month is due or 1 week after, so either on week 3 or week 5. And again, if the patient is uncomfortable in withdrawals or it's not quite covering them, you can also add in the little weekly 8 milligram injection. And the maximum dose of the monthly is 160 milligrams. I've never seen anyone need more than that. And they were the really heavy users. So it does cover them well. I think they've worked out the right doses for patients. And yeah, it's been really beneficial. And this is the injection sites. And the nice thing about the labes is that they're subcut injections. They're not intramuscular. So you don't have to worry too much about hitting sciatic nerves and things like that. And they're the different sites that can be injected. Now, when you administer the Buvidal, it's a very easy way to do it because they're preloaded syringes and just single dose preloaded. So all you do is do a pinch up of the skin and directly 90 degrees straight in, and then put plunger down, and then you must pull out the needle before you take your thumb off the plunger because the needle quickly retracts back into the syringe, and you don't want that happening while the needle's in the patient. So they're very easy to use and very safe as well to use. And then there's a little bit about the safety profile of Buvidal. I mean, our experience was it was very well tolerated. Yes, there's a few, adverse effects there listed, but as you can see, they're really low percentages, mostly. And, from clinical experience, no one really complained. They said they tolerated it really well. They might have had a little bit of injection site pain, but that was about it. Mostly they were really happy on it. So in conclusion, the benefits that I found, my experience was, it was fantastic. And because there was less variation in their dose compared to Suboxone, they were very stable. It certainly eradicated their cravings. They really were not interested in using illicit drugs anymore. And I felt that they basically overall became more settled. And there was less need for any PRNs. They weren't interested in benzos, or they didn't need their quetiapine anymore. They'd slowly sort of dropped off. Obviously, they were able to travel now, which was lovely for them. They could go to work. They could do FIFO if they wanted. They certainly saved money. And 100% their lives improved. And that's what we saw. And the benefits have continued because the uptake has continued. And just one little graph to show, well, this was at the end of 22. You can see that the uptake of the labs was already 26%. And I'm sure now at the end of 2025, it would be probably 50%. And that's it. Any questions?
I have a question, Catherine.
Yeah.
In the earlier slide, you showed an excess number of deaths in the older users.
Yeah.
Has that been qualitatively studied to find out why? I mean, they're supposedly more experienced users, or are they just kind of using more intermittently and therefore having periods of relative withdrawal and then dosing themselves inappropriately highly and dying? Well, what's going on there?
Yeah, I found that interesting too, Leighton. I don't know, to be honest. Probably all what you just mentioned. Yeah, it's hard to know. Yeah, that's right. Oh, yeah. I'd say so because, it's so easy to have an accident with it. Like you're already taking benzos and everything else and probably, major tranquilizers and all those things. And then patients do make mistakes, they think they just have extra of what they've got, they're not doing well. So they'll say, well, I'll just take more and more and more of whatever the opioid they've got. And next thing they get respiratory depression. And they didn't mean to kill themselves. It just does happen, especially in combination with those other sedating medications. Yeah.
Like the Heath Ledger effect, a little bit of this, a little bit of that, a little bit of something else.
That's right.
Drinks and go to bed and don't ever wake up.
That is a very good analogy. Yeah, it is like that.
And older patients also, their tolerance drops as they get much older, with medical complications, and then they're in and out of hospital, and they don't, and when they're like much older, many medical staff, they don't really talk to them about the harms of an accidental overdose with their tolerance dropping as well. And then they go back and then they use the same. We do see quite a lot of the supply composition changing as well. And sometimes you have it in the news that, the latest supply of heroin is laced with something else, and it increases accidental overdose. So, yes,
Fentanyl, yeah.
that's right. And what they think they're buying could be a lot higher. Yeah.
That's true. Mm-hmm.
It's on the PBS, I presume.
Yes, it is.
Well, your private patients, I previously would have been only supplied through the health department and Next FI.
Yeah, that's right.
And is it a complicated process? I mean, you have to be a registered prescriber.
Yeah.
But is it a complicated process through the PBS to get?
No, you just write a prescription.
Right.
Yeah, which you send to the pharmacy. So they're basically buying a box of Suboxone, which is basically daily dispensing of that. Yeah. So it's the cost of the script, really.
And long-acting injections, you don't have to meet the criteria. I mean, obviously, you have some criteria, but it's you can do the online. You do an online authority application.
It's the same process of applying. There is a form, an authority application.
Yeah, yeah.
And there's also a new consent as well. You have to have a consent the patient again, and then you send all that off to the Department of Health.
So there's prior permission from the Department of Health.
Yeah.
You've got to have that prior in writing, presumably.
Yeah, in writing.
Yeah, and then a PBS application would be a lot simpler after that.
That's it. Yeah.
The only hurdle is to go for the training. You need to do the OIC training. And I think just if you want to do just prescribe buprenorphine and Bovida, it's an online course. But methadone, then you have to go to the next step, and they have training sessions once every few months. You just put your name down and they'll call you. Yeah. Which is a lot easier, because in the past it was like the buprenorphine and methadone, you had to go for like a whole day session.
And you have to be reaccredited every 3 years.
Yes.
Mm-hmm. Yes. Right. Yeah.
What are the criteria for determining the patient on long-acting preparation as opposed to?
Well, it depends what they want as well. Like a lot of patients really love the idea of being able to travel and not have to go to a pharmacy every day. But having said that, some patients really like going to a pharmacy every day. And it's really good for them to get up and get out of the house every day. And for those patients, we think they should probably just stay on the Suboxone, because there's so many benefits of just gets them out of the house every day.
Yes.
And I found that some patients they lose something if they lose that, Now there's no reason to get up in the morning and go and dose. And it becomes a bit of a social thing too, They get to know the pharmacist really well, and then they might go do their shopping or go to a coffee shop or something like that as well. And so it becomes like, a daily nice thing that they're doing, Sadly, there was one patient that really wanted to go on the injection, and he was an engineer and he wanted to do FIFO work. So we said this would be, a great treatment for you. And he really wanted it himself. But he had a lot of underlying, depression and suicidal ideation as well. And the sad thing was he actually suicided when we put him on it, because his mother said that what he lost was that going out every day to the pharmacy. And that really was a wake-up call that we can't put everybody on it. It's not for everybody. Yeah.
I've had patients tell me that it gets them up to dose and then go to work. And without that, the long acting, they tried a month or two, and they don't go to work. They don't find that motivation. Just before dosing, they have a small period of a bit of withdrawal. It's like it actually makes you want to get up and go and dose, and then they feel better, and then they go to work. And that's their routine, you see. So yes, it's not for everyone.
And also, if they're really stable on the program and now they've got takeaway doses, they're not going every day now, So sometimes you're just better off leaving them on what they're already on. They do well on that.
We find that the rural patients, they do benefit on monthly, don't they?
Yeah.
Yeah, because many of them tell us that they don't want to be seen in the small town dosing every day in the pharmacy, because there's probably one pharmacy, and and everyone knows everyone.
Small town gossip.
Yeah. So they are very keen that before we discharge them, they go from a few doses of daily Suboxone to monthly. Yeah.
Yeah, we had one patient from Meriden.
Yes.
And she used to actually work in the pharmacy.
Yeah. Yeah.
So the last thing she was going to do.
Like to spread out the back, surely.
So the last thing she was going to do was go to the pharmacy. So she insisted on opioid withdrawal, which was kind of risky, but there was no way she was going to go on that program.
You mentioned those FIFO patients, and some of them work in high-risk industrial environments.
Yeah.
What are the companies that employ them and the occupational health physicians that often have to certify them? What do they have to say about working in those environments? And is that possible? Are there complications from the long-acting ones that preclude that?
No, they don't. It doesn't have a huge sedating effect, and you can, like they say, when you first initiate someone on Suboxone, they shouldn't drive initially or operate heavy machinery. But after, I don't know, a week or something, then they can, because it's like they just don't have that sedating effect with it. But they do say that it's up to the patient, whatever industry they're in, to know what they have to report or not report. So it's sort of the onus is on the person taking it to find out if where they're working, they have to tell them or not tell them.
It won't show up on a urine drug screen or a saliva drug screen.
It does.
It does.
Yeah.
And they should tell them.
Well, then they should, yeah, if they're going to have that. That's right, yeah. And we can give them letters as well to say that they're on a proper medical treatment. Yeah.
I have given letters that they are fit to work. Also on the monthly, it's not very sedating at all. And the big companies like Rio Tinto, they're actually more accepting of this these days. They're quite open, and they want to be supportive of their employees.
We look at the alternative.
Yes.
Employees who smuggle drugs or take a heap of drugs on their week off, and then are affected when they go back the first few days or something like that.
Absolutely,
So
yeah.
it's probably a lot safer than the alternative.
That's right.
In every respect.
Yeah, in every respect. Yeah. Data.
We probably do have. Yeah, we do have patients who are on Suboxone. I know it says 2 years as an average, but the ones that we see in the tertiary setting, so not really at a primary, like a GP clinic or private outpatient clinic, we actually see quite severe opioid users, and they're on it for years, even 10 years. And we try and initiate coming off, but coming off is of their injectables or their daily OST is so destabilizing, and it's still too early, like despite years of being on this. So that
relates to severity.
yes, and definitely coming off their OST. Sometimes it's recommended like within a year or two, the relapse rate is a lot higher. It's a lot higher. especially if the reasons of coming off could be cost. Daily dosing at a pharmacy or even buying the injectables. I think in next step, there's probably only one e-squirt that we can get
For free.
for free
Yeah, I don't even know if you can anymore. I think
Yeah.
now it has gone out to the community.
to the community.
Yeah. Mhm.
I know it is such a no-brainer, like, spending all the money on illicit drugs versus buying your script, but many of our patients are impulsive, and the instant gratification. So they feel like, if they have to spend all that money, sometimes there is a reason for them to stop.
But some people are ready to stop.
Yes.
And the way we stop them, if they're on the injection, we just basically let it wear off. And it just seems to sort of just taper. But at the tail end, they might start getting withdrawals. And then we might just use a little bit of Suboxone or a little bit of the Subutex and just do at the tail end, just a real gentle little wean, and people do come off. Yeah. And if they're on Suboxone, it's just a gradual reduction in their dose until they're off. And it can be a very, very slow taper off. Needs to be usually. Yes.
Just finding some of those really
What do you mean?
Psychotherapy.
Oh, yeah. You mean like the wraparound services?
Yes.
Oh, yeah. I mean,
The next step, they have case managers.
they have case managers,
They go for
counselling.
smart groups and meetings.
NA.
for those requirements of participation in a program like that.
No, they're not requirements, because really you just want to treat this patient that's so unwell. So you just want to get them onto a program, as soon as possible. But you do encourage them to make access. Yeah, but the program itself covers them, Dr. Woodall. The program itself, it fills up their receptors with the buprenorphine so beautifully that their cravings go away. It stabilizes them. It's just the ones that keep sort of coming on and off the program.
Comorbid mental illness.
Comorbid, yeah.
Once we take away the self-medication, we actually see the underlying illness, and that's when it's perfect. So in Ramsey addiction unit, it's usually a 2-week admission, and the first week is all about trying to get them off their illicit substances, one way or another. And then the following week we actually try and establish some kind of a mental health diagnosis if they still do struggle, and then we start off the treatment and give a good plan to the GP, or we might see them outpatient if they are quite severe, and we try and treat both at the same time. But we do recommend, especially the ones that are very severe users and poly users as well, that that they go for some kind of smart recovery or AA, because sometimes when you take away one drug, one illicit drug, another one goes up. Yes. So they could, like, most of them could be like smoking from a 20 pack a day to 40 pack. Like, they're like trying to cope, and then we sort of like find out what is it that's left to treat. But like Catherine said, many of them do so well with just OSD and back into work, and
Yeah, they do. But Next Step does have a fantastic service. There are social workers, there's legal aid there, there's counselling, psychology, and they get access to all of it. And, it's really good. And they get a lot of support.
Tendency to have a mix of drug use. What are your impressions of the issues that were revealed from the ready availability of these channels?
Oh, yeah.
Having help everywhere in Australia.
it's complicated and it's quite concerning as well. I did read somewhere in the news this morning online that the chair of the medical board said that it's patient demand is not an indication for medicinal cannabis, and the rise of scripts for the high THC medicinal cannabis has gone up, which is very worrying. And I don't know whether y'all are aware, just a few weeks ago in New South Wales, they were going to start rolling out something like it's fit to drive on medicinal cannabis. So it's all a bit worrying, you know, in this space. I do advocate for medicinal cannabis when it's harm minimization. So you've got patients that are very debilitated with their cannabis use, but mostly they start with just, I'm not a prescriber, but you know, you sort of work with a GP that prescribes, but mostly CBD oil or a low THC, and then you treat the underlying mental illness. And why is it, you know, they sit at home and smoke all day? Could be ADHD or autism or severe depression, anxiety, insomnia. You know, the reasons why people use cannabis, it's more of a sedative. But it is so worrying, the prescription of medicinal cannabis.
That's a final question. After discharge, you're not following all these people up. You've got to refer them off to a registered next step or registered GP.
Yes.
Yeah.
Do you have trouble finding some of those people?
No, not at all.
CPOP actually helps us with
Yeah.
that.
Okay.
Yeah, there's this community program of opioid pharmacotherapy, which is the overseeing body, and you they just look after everything. They will find that appointment for the patient.
And I know it's a completely different drug, but any benefit on methamphetamine users with the long-acting agents?
Some prescribers have tried, but it's not an indication.
It's not really an indication.
Yeah.
It probably does have some benefit though, because they're more stable.
Especially if they use methamphetamine as a primary drug, but they use heroin every few days to sleep it off.
As a come down, yeah.
Yes, as a come down.
Yes.
Yeah, or you can have the other way around. You can have like heroin users who use heroin primarily, and then as a PPR, you have methamphetamine